Javed Khan. Thank you very
Thank
much for your warm introduction, and thank you that trust me to give a talk about PROL0THERAPY, that we already built this treatment for 8 years in our center, and we believe with sharing knowledge, we also sharing happiness. As you know, that's India and Indonesia had a good and great relationships. And as you know also that we have a great connection for long time ago, that you know that Islamic religions spread out also from Gujarat prefecture. And until now, Indonesia, our President Jokowi, and your Prime Minister Modi also have a good relationship. And a lot of Indian people also live in our country and have their own community. And you know that's the Hindus biggest island in Indonesia, the most famous island in this world, also have had a lot of Indian culture. As you know that Bali is part of us, part of Indonesia. And I hope that our relationships between Argos Pain Academy and now Jakarta Pain School, that we already started as a big brother of Argos Academy from 5 years ago. We started at, I think from 6 years ago at 2018, could increase the relationships, and I hope that as my brothers mentioned to me that Pajajaran also could support it, and it's still under discussion between our dean and our rector, and as soon as possible, if there's answer from our leader in our university, so you could put it on your academic.
Yes, thank you very much.
Yeah, and now as Dr. Javed asked to me, I share my knowledge about PROL0THERAPY. Okay, now let's start our journey. There's a slide about the Indonesia experience in PROL0THERAPY.
You can start sharing a screen, Dr. Alif.
Yeah, start. Okay. When you come and visit to my country, also visit my beautiful city. I have my beautiful city. The name was Depok. That's the near with Jakarta, only half hour from Jakarta. And we have also mountain. We have also the everything there, and you will love it. And my city also have me, so they have a beautiful life. And this is my first batch. We started our fellowship program at 2020, and now we already have it 256 fellowship. And my great thank you that my friend from Bangalore, I think the smartest pain intervention in Bangalore and Karnataka states, Dr. Khaja Javed Khan, also help us become one of the international faculty, that now you already help us to make it 256 fellows, not only around Indonesia, but around Southeast Asia. And now let's start about PROL0THERAPY. PROL0THERAPY, also known as proliferation therapy or regenerative injection therapy, or proliferative injection therapy. The old terms before is also mentioned about fibroproliferative therapy or proliferant injection therapy. But the definition from the books that write by Hemwell and friends,
Dr. Alif,
yes,
the slides are not seen.
now see it?
No,
Okay, okay, I will start it.
we share the slides. Yes.
Okay, I will restart it. Wait, wait, wait a second.
Yes, sure.
I will restart my slide. I'm sorry for the disruption
No,
about this. So sorry.
no problem.
Okay, I will try to start it. What do you see now, my slide?
Yes, it is starting.
It's just starting.
Yes, now it is seen.
That's my beautiful city, Depok. You see it? Welcome and visit my beautiful city, Depok. The city with the 3 million people live there. I live there also. And just that I mentioned before, that's our first batch. Now we have 8 batch, and we have already 256 fellows around Southeast Asia. And Dr. Javed already involved in this fellowship program start from 2020, I think. And that's the definition of PROL0THERAPY. And Hemwell also mentioned about the PROL0THERAPY. The definition from Hemwell was involved injecting an otherwise non-pharmacological and non-active irritant solution into the bodies, generally in the region of the tendons or ligaments, for the purpose of strengthening the weakened connective tissue and alleviating musculoskeletal pain. That's the early definition of PROL0THERAPY. And we have differentiation. The first group mentioned about PROL0THERAPY was dextrose PROL0THERAPY. But as you know, the other groups mentioned about the PROL0THERAPY is not only dextrose, but dextrose, the PROL0THERAPY was the regenerative intervention treatment. There's a fourth kind fluorotherapy that's well known in this world. First, the ozones, that Indian have also increased number of the ozone users for MSK. The name was PROL0ZONES. The other was dextrose solutions. That the other groups mentioned about PROL0THERAPY was the dextrose, but in our World Association now, the PROL0THERAPY is not about the dextrose only. But PROL0THERAPY, it's mean about treatment of proliferation, treatment that make proliferation of the tissue or the structure. So the other part of the PROL0THERAPY, the other kind of PROL0THERAPY was platelet-rich plasma, and the other was stem cell. But in this slide, I will talk only about the dextrose PROL0THERAPY. And now we start our voyage. Let's become Captain Jean-Luc Picard with the USS Enterprise, explore the new world, explore the beautiful world, explore the other galaxy. Okay, before we start a new world, before we start to explore the other galaxies, so we must know about the history. And how about the PROL0THERAPY history? As you know that there's 2 doctors that's well known about this treatment. First was Dr. Josh S. Hackett, and second was Gustav Hemwell. The Dr. Josh Hackett was family medicine doctor, but Gustav Hemwell was trauma surgeon. Hemwell was a surgeon. So it's possible the surgeon involved to this part. Not, it's possible also the other doctor, including anesthesiologist, including neurologist, including general medicine, including general practitioner, family medicine involved to this treatment. Not only pain interventionist only. And you know that in the Roman times, there's the first PROL0THERAPY treatment used by the doctor that make a hot pocket on hot needle into the shoulder of injured gladiators. And the 1940s and 1950s, Hackett and Hemwell extensively used it. And the term of PROL0THERAPY was first used in the 1950 by the Dr. Josh Hackett. But in 1959, US banned about this treatment. Why? Because there's not only dextrose that they use it, but the other kind of fluid, they use it to do the treatment of PROL0THERAPY. And there's one or maybe two patients died because due to this treatment. But at 1991, Alan Banks, PhD, orthopedic surgeon, described in detail the theory behind a PROL0THERAPY in Rational for PROL0THERAPY in Journal of Orthopedic Medicine at 1991. And after that, boom, PROL0THERAPY become widespread around the world. That's the history. And the history of PROL0THERAPY, the basic science was to stimulate inflammatory healing or regenerative cascades. Hippocrates and the doctor Hippocrates, I think the first doctor in this world, used a hot poker in the axilla to repair a dislocated shoulder of the gladiator. I think it's around 400 before Christ. And at 1800, they inject iodine solution to treat a hernia. And as I mentioned as in the previous slide, in the mid of 1950, Josh Hackett observed that following injection therapy at the junction of the ligament and bone result in profuse proliferation of a new tissue. And what kind of solution that they use? It's not only dextrose, but they use also lidocaine. They use also phenol. They use also glycerin. They use also cod liver oil extract. They use also sodium urate until now. They also use P2G that contain phenol, glycerin, and glucose. But the famous of PROL0THERAPY was hypertonic dextrose. That causes osmotic rupture of the local cell, increase glucose in extracellular matrix that provides local tissue irritation that initiate an acute inflammatory response and improve fibroblast proliferation and subsequent collagen synthesis, which provide healing and tissue renewal. Now, we start our journey. Dextrose. They have some concentration, 1%, 5%, 10%, 12.5%, 15%, 25%, and 50%. The cut-off, the high and low dextrose PROL0THERAPY was 12.5%. But you must know, PROL0THERAPY until now, the mechanism until now are not fully understood. Exact working mechanism is still a topic of research until now. And then no studies have compared the relative proliferative effects of differing concentration between 1%, 5%, 10%, 12.5%, 15%, and 24%, 50%. There's no studies to compare it. And need further study to determine optimal strategy, including dextrose concentration and volume, treatment, frequency, and duration, and also specific utility. But I summarize about mechanism dextrose PROL0THERAPY. There are 6 mechanisms of dextrose PROL0THERAPY. First, dehydrating cell at the injection site. So it will make leading to local tissue trauma, attracts granulocyte and macrophage, and also promote healing. Second, bind to presynapse CA channel and inhibition of the release substance P and calcitonin gene-related peptide, or they mentioned about the CGRP, I'm sorry. Third, increase gene expression in angiogenetic factor, PDGF, alpha and beta, also insulin-like growth factor 1, and VEGF-A, and in apoptotic factor in fibroblast, Cas-P and Cas-P8. The dextrose also bind and inhibit TRPV1 nerve receptor. That's interesting. As you know that the Nobel Prize winner at 2021, they mentioned about this one, the TRPV1. The other mechanism, dextrose also help to hydrate and improve the sliding of connective tissue and improving muscle damage by decreasing serum of LGH and CL level. There's also studies, original research at 2016. They have a research about the chondrogenic effects of intra-articular hypertonic dextrose in severe knee osteoarthritis. The conclusion of the results was the intra-articular hypertonic dextrose, 12.5% injection associated with the chondrogenesis in area of exposed subchondral bone in participants with symptomatic grade 4 OA knee. Interesting. And participants improve clinically in self-reported and objectively assessed functional outcome. Wow. The others. The basic knowledge of PROL0THERAPY was inflammation. As you know that inflammation is necessary for healing. And they have 3 cascades. Inflammation cascade, proliferation cascade, and remodeling cascade. They have a 3 phase. And inflammation is around 4 until 6 days. Proliferation is around 4 days until 24 days. And the remodeling was 21 until 2 years. So that's the reason why when we do PROL0THERAPY treatment, is 1 week until 2 weeks, and it's possible until 3 weeks. Why? Because the proliferation cascade starts from day 4 until day 24. Okay. And how about the other journals? International Journal of Medicine 2018 also explore about dextrose PROL0THERAPY in contusion injuries in mice. And the result was PROL0THERAPY was promoted muscle cell regeneration or desmin protein increase after contusion of injury, improving muscle damage by decreasing serum LDH and CK level, and facilitated effective muscle recovery after contusion-induced muscle injury. So you must know about the Thanos and Hulk, the good man and bad man, I think. But I don't know. Now I don't know how. And now I I don't know which one the good man and which one the bad man. I think Thanos and Hulk have become a good man now. But as you know that there's a protagonist and antagonist. Yes, the agonist was anabolic factor. The green one was anabolic factor, and the other was the catabolic factor. How about the other results? They also have a result about PROL0THERAPY induced an inflammatory response in human tenocyte in vitro, and exposure to PROL0THERAPY solution with P2G and glucose decreased the metabolic activity of the tenocyte, increasing pro-inflammatory markers including IL-8 and COX-2, and decreasing of the AME, the anti-inflammatory markers. That's the result from 2017. And now, how about the definition? The new definition of PROL0THERAPY was a form of injection aimed at the ligament, inviting inflammation and aiming at healing. That's proliferative, stimulate growth, regenerate, and rebuild. So, how about the spell? The spell was relief. With the use of the PROL0THERAPY, I have a lot of patients relief from pain. In the respected medical journal is mentioned about that. And for more than 60 years, with up to 85 until 90% have a good until external results, that a degree of enthusiasm was generated. So, why to use it? And then, how about PROL0THERAPY compared with cortisone? The effect on healing, enhance. Effect on repair, enhance. Effect on collagen growth, enhance. Effect of the tendon strength, enhance. Effect the ligament strength, enhance. Effects of the cartilage growth, enhance. That's cortisone. All of them is inhibited. So, we still use steroid? It's up to you. And then, how about the treatment protocol? First, you must ensure a true ligament insufficiency and stimulate a limited inflammatory response, trigger the healing cascade, increase fibroblastic activity and collagen deposition, strengthening the ligamentous structure, and relieve the pain. You must believe about this. And how about the preparation? To become number one, we must have a good preparation. So, the preparation was no aspirin, no anti-inflammatory drugs, no anticoagulant medication for 3 days. Second, there's no pain medication prior to the procedure. Third, it is important to be in pain at the time of the procedure. See, it is important to be in pain at the time of the procedure. So, you must inform your patient. We will generate soreness and stiffness. If there's soreness and stiffness during your treatment, it's a good news for you. And insulin and oral diabetes medication take usual dose. No need to stop. And patient taking cardiac or blood pressure medication may take usual dose. How about the contraindication? There's relative no contraindication except for immunocompromised, smoker, poor nutritional status, insufficient conservative treatment, the needle phobia, and allergy to proliferant solution. And how about the post-procedure? The post-procedure was no driving after the procedure. There's no driving. You must ask your patient to take the online cab or ask the other to become a driver before the procedure. And second, no anti-inflammatory drugs for 5 days. There's no NSAIDs until 5 days after the injection. Third, paracetamol is accepted. So when your patient gets soreness, give paracetamol. And light activity for 3 days, resume normal activities on day 4 following treatment, and patient may have increased soreness and stiffness averaging 2 days post-procedure. So, how about the complication? Increased pain, dizziness, and nausea, numbness. But there's no complication. Beside 3 of them. No scarring, no infection, no abscess, no weakness, no spinal headache, no allergic reaction, and no other disability. And how about our experience? We have studies that from July 2019 until May 2020, we have 486 cases. The first rank was PROL0THERAPY of the knee. The second rank is PROL0THERAPY around the hips. And the summary of our cases, the most cases was lower extremity cases. The less cases was spine cases. So it's not a lot of spine cases that become a problem in our country. As you know that in PADS number was not so lots. So don't worry about NPH, but worry about the lower extremity and the upper extremity. And that's also the way and the concentration to do the injection. In these studies, they use dextrose 25% and plus 0.1 lidocaine. It's okay when you added lidocaine a little bit. And how about the other studies? There's 94 patients from 201 until 205. The average FAST score was 7.1 and become 2.3 when they follow up 20 months and average the PROL0THERAPY 3.8. It's good news. The other was mentioned about the effectiveness of PROL0THERAPY in the treatment of chronic rotator cuff, and PROL0THERAPY is easily applicable and satisfying auxiliary method in the treatment of the chronic rotatory cuff lesion. And how about the shoulder? Voila, I have a beautiful result about the shoulder. I have a case. I think Javed, I have my slide about the adhesiolysis with the low dextrose injection. One injection get 4 compartments, and that's so beautiful. And I explored this technique from the Turkish. Turkish use it for the chronic shoulder pain, but they use with the fluoroscopy, and they use the triple shoulder injection from SA joint, and they get 3 compartments. But I think, wow, why not we use ultrasound? And voila, the ultrasound result was wonderful. I do almost 100 patients, and until 2 years follow-up for the frozen shoulder, there's no the patient, there's no complaint at all after 2 years. The FAST score 2 until 3 after 2 years. Then and the range of motion was absolutely normal. Wonderful. Masya Allah. That's we use the Alif technique. Previously, the Turkish used with the fluoroscope, and I used my technique from SA joint before. And I used the PROL0THERAPY treatment 1 week until four times, and I follow up from 3 weeks, 6 weeks, and the FAST scores down from 8 become 1, and the abduction that lasts from 45 degree become 110 degree. Wonderful. And how about the knee? The knee also have the good result. The therapeutic effect of the PROL0THERAPY with the intraarticular dextrose injection in patient with the moderate knee OA, they follow up until 24 weeks. And the treatment with the 3 intraarticular injection hypertonic dextrose given the 4 weeks apart, and the result was wonderful. that's the how to do the PROL0THERAPY. We do injection with intraarticular and extraarticular, and we do it in the MCL, pes anserin, tibial tuberosity, coronary ligament, patella, LCL, and intraarticular injection. We also do the hip PROL0THERAPY, that's my journal, and the result was amazing. And that's how we do it, the PROL0THERAPY. Before the PROL0THERAPY, the patient cannot stand, she only lying down, and the doctor planned to do the total hip replacement, but the blood pressure more than 200 and 150 for systole and diastole, and after do the GA, the blood pressure not coming down, and they abort the procedure, and the patient still getting pain, and they come to us. We do the PROL0THERAPY with dextrose 10%, 4 times once a week, and see how about the result. Voila, wonderful. And that's how to do the PROL0THERAPY on the back pain. And that's my friend from Egypt that I will come to Egypt next week. Then he mentioned about the significant and sustained reduction in the neck and low back pain were observed for 1 year's follow-up. 50% reported 85% improved, 24% reported 75% improved, 20% reported 60% improved, and only 6% reported non-improvement. So it's good adjuvant in spine management. So why we not use it? And PROL0THERAPY is divided become four. First, the PROL0THERAPY itself, the name was read, the regenerative injection therapy. It means that injection of hypertonic dextrose to treat chronic muscle pain, chronic musculoskeletal pain. And the second one was perineural injection therapy, the injection of dextrose adjacent to peripheral nerve to reduce neuropathic pain. That's the definition of perineural injection treatment. My friend from New Zealand, from Christchurch, do the lift-off perineural injection treatment, neurofacial PROL0THERAPY. The others was hydrodissection. How about definition of hydrodissection? Dextrose injected adjacent to peripheral nerve with continuous ultrasound guidance to release peripheral nerve from their encasing fascia in order to provide a decompression effect. And voila, there's a new one, fresh from the oven, perineural subcutaneous injection or glucopuncture. We have my own style to do this. And first, is mentioned by Jan Kersot from Antwerp University. He used series of regional multiple dextrose 5%. Yeah. And we in our country modified it become dextrose 12.5%. Yeah. I will explain why I modified that. Why? Because we have experimental studies that it explain about when you use dextrose 12.5%, it will decrease the number of TRPV1 and will increase the capsaicin receptor, and you start your magic. And the basic implementation, now there's a shifting changes. Previously, we mentioned about the pain management, but now we mentioned about pain intervention. There's a big difference between the pain management and pain intervention. Why? As you know that when there's tissue destruction, it's like a house like have a fire, and we call our officer to shut down the fire. The fire was the pain generator, and that's pain management. The pain management is only like that, shut down the pain generator only. But now it's different. The new era come, the pain intervention come. But pain intervention is not only shut down the fire. It's not only shut down the pain generator, but also build it the new house that already fire. The mention is about regenerative treatment or orthobiology. We could use ozone, PROL0THERAPY, PRP, PRF, platelet gel, plasma lysis, A2M, BMAC, and stem cell. We also, in fact, develop about neuromodulation, and we also now develop our own minimal invasive. That's the pain interventionist. Not only shut down the tissue pain generator, but build it a new house, build a new building that already shut down by us. And you know the scope of pain intervention previously is only injection with getting ultrasound, fluoroscopy, or CT. Is possible block or RF or block with radio frequency. But now it's not only that. We also develop about orthobiology. We also develop about neuromodulation. We also develop minimal invasive. That's a pain interventionist. We solve the root causes, not only symptomatic problem. Okay, I will explain about this, and voila, there we explain why I use glucopuncture. That's the reason why I use glucopuncture. And see the next slide. You see that the TRPV1 is in the level of the epidermis and border between epidermis and dermis. And you know that the TRPV1, the receptor that responsible for pain receptor, that for pain, the most common part was in the hair follicle. So from the mast cell, from the hair follicle, from sebaceous gland, or from the border between the epidermis and dermis, it will connect to the DRG and will connect to the spinal cord by peptidogenic fiber unmyelinated, non-peptidogenic fiber unmyelinated, alpha beta fiber myelinated, and alpha gamma fiber myelinated go to the DRG. That's why I use glucopuncture. Why? Because the pain receptor, the depth of pain receptor only in the hair follicle only. So it's no need to inject deep full. It's only inject in the superficial part. It's only like that. And as you know, that's at the 1860 and 1862, there's a surgeon, the name was John Hilton. They have observation in studies of anatomy, the nerve supplying the muscle, extending directly across and acting a given joint, not only supplies the muscle, but also innervate the joint and the skin overlying the muscle. So from the source under the skin, they have the same nerve. So when we inject in the skin of L4, it will go to the L4, and it will connect to DRG L4, and will go to spinal cord. That's the glucopuncture. And we also already published it at the Pain Practice Journal at September 2020, volume 2, because supplement 1, we published that that glucopuncture is not only in the knee OA, but also in the gonitis TB, spondylitis TB, knee OA, CRPS, and vertebral fracture without motoric and sensory disturbance, and the patient doesn't want go to operating theater. We do that. And we also develop about knee OA grade 4. You see, we do this. We do only percutaneous fibular osteotomy. That's the incision. And we use that for knee OA grade 4. And use it. That's the before. And in this moment, we do the osteotomy, and the other part, they do knee replacement. And you see, The part that we do only percutaneous fibular osteotomy and injected glucose in the medial compartment is better than the knee replacement part. You see it in the right side. Both of them also do the knee replacement. No, the right side do the knee replacement. The left side, we do only percutaneous fibular osteotomy. You see the Khaja there, and we only do percutaneous there, and you see how about the result. It's so different. And that's a mechanism that explain about why we do proximal fibular osteotomy in the treatment of the medial OA of the knee. That's my paper that already published. We do in the 6 patient with the heavyweight woman champion, and we do observation until 2 years, and we have a good result about the pain relief and functional improvement with more than 50% of score pass and WOMAX after the treatment. The patient received 12 doses of intra-articular dextrose PROL0THERAPY due to the lag progress, and the others give 8 times dextrose PROL0THERAPY. And we compare also between the PFO with the HTO for treating knee OA. Then the result was PFO have the better results. And that's my sentence. And new pain intervention generation not only solve the symptoms, but solve problem behind the symptoms. And always remember that God's Allah Subhanahu wa Ta'ala heals and prayer strengthening. Thank you very much. Assalamualaikum warahmatullahi wabarakatuh. Good morning.
Thank you very much, Dr. Alif, sir, for a very insightful and wonderful session on PROL0THERAPY. Definitely, thank you for sharing your experience of the patients you've been doing on in PROL0THERAPY. In India also, we have been doing PROL0THERAPy for a few patients, but your experience definitely will help us. I'd like to ask the participants if you have any doubts. Dr. Alif is here. We can have a question and answer session, clearing of doubt session. I think somebody has raised their hand. For the others, I'll tell you can message in the comment section, and I can ask the questions, or you can raise your hand and you can directly ask. Dr. Harun has raised his hand. Do you have any doubt, Dr. Harun? You can unmute yourself.
Okay, thank you very much, Dr. Alif, for your lecture. I just want to ask about how if we mix the dextrose or steroid with the PROL0, if is the effect is more good or not? Thank you very much.
Yeah, thank you very much for the great question. Is it possible I answer directly, Dr. Javed?
Yes, sir. Yes, sir. Please go ahead.
Okay. Dextrose and steroid have the same effect. Have the different effects. The steroid was anti-inflammation, so it will shut down the inflammation. Dextrose will promote the inflammation, will promote the soreness, will promote the stiffness. So when you do only treatment for PROL0THERAPy, it's not wise to use both of them directly. Why? When you want to do proliferation, when you want to build something, you make it a fire in the other part. Not wise. So in my experience, and that I know about this one, we could not mix between the steroid and dextrose in the same part when we want to do the proliferation treatment. That's my answer, Dr. Harun. Thank you.
Thank you, Dr.
Thank you
Alif.
very much for your answer.
Thank you
Dr.
very much, Brother. Is there any question?
Doubts? You can unmute yourself and you can ask to Dr. Alif.
I hope my slide will inspire all of you to do this one.
One more question, Dr. Japet.
Please go ahead.
Thank you.
Okay. Dr. Alif, do you have any experience in using the PROL0THERAPY in ganglion block?
Okay.
Yes.
Lah kemarin udah kok, masih kurang.
When I know that you mean about the ganglion kiss or ganglion block. I don't know. When
The
you use
ganglion.
when you use for the ganglion kiss, we could use not probably we could use the different concentration about ganglion kiss. I've experienced that when I use a Beckett kiss, we have a Beckett kiss. I operate 2 times, and it's appear again. And I do with my own treatment. I do with my own style. I do with the dextrose 40%. Dextrose 40% is mean that it's not PROL0THERAPY, but it becomes sclerotherapy. The sclerotherapy will make this with the kiss will shrinkage. We have a Beckett kiss. You know, Beckett kiss, the biggest kiss in the posterior knee. We have experience with that cases. We do it 2 times, and voila, until now, 3 years, the patient doesn't have any complaint at all. But for ganglion blocks, I don't have any experience. And for the ganglion blocks, there's no recommendation to use dextrose. There's no recommendation. For ganglion blocks or sympathetic blocks, the recommendation use with the phenol and alcohol only. So for the kiss, ganglion kiss, you could use dextrose with the higher concentration. It's above 40%. The some paper use it the dextrose 75%. But for ganglion blocks, there's no recommendation at all for use it at the ganglion block. Thank you.
Okay, thank you very much, Dr. Alif, for the answer.
Thank you very much.
Dr. Alif, I am having a doubt. I want to ask you.
Yes.
When you are doing the PROL0THERAPy sessions, especially for musculoskeletal indications,
Yes.
so usually how many sessions do you do, and at what intervals do you do the sessions?
Thank you very much. In my experience in my country, I use it for usually 3 until 5 times. The cutoff when I do it after at the 3 times, I ask the patient how about the results. When there's a progress, the good progress for the result, I continue the procedure. But when there's no progress at all, or only little bit progress, I stop the procedure.
Okay.
The interval is 1 week. Usually I do it every 1 week.
1 week.
Yes.
Okay.
Thank you.
And do you do the PRP and PROL0THERAPy in the same session or no?
No. We have a pyramids that define about the PRP and dextrose PROL0THERAPy. Some person mentioned about PRP was PROL0THERAPy, but the others make different about make it different about dextrose and PRP. But when we use dextrose and PRP at the same time, no. We use it's different. Yeah. The mechanism is similar,
Yes.
but when we have a scale, dextrose PROL0THERAPY was good, PRP was better. But you know that dextrose was cheap. It's so cheap.
Yes.
And it's nice in our country that you use the cheapest one. PRP is more expensive than dextrose. So in my center, I use dextrose first. I use
Okay.
dextrose first, and the cut-off when after the 3 sessions, I ask them, how about the result? When the result, oh doctor, there's no result. I still have pain. I still have like this, like this. Okay, okay. Shut down the procedure. Don't do the procedure. Shut down. You must choose the other. But, doctor, you're the best. I lucky to have you. So, continue procedure until 5 times. Thank you.
Thank you for the amazing explanation, Dr. Alif, as always. So we have a question in the chat box by Cynthia Yaputri. Amazing presentation, Dr. Alif. I want to ask about where you inject for shoulder PROL0THERAPY, and is it suitable for labrum tears?
Okay. For shoulder PROL0THERAPY, usually I use for the chronic shoulder pain or I use for the frozen shoulder. When I use for the frozen shoulder, does not include for the AC joint part. I do with my own technique. I start from the medial with ultrasound and I inject the structure that elevated the coracohumeral ligament that connecting between the subacromion and subcoracoid. And where we do in this part, in one injection only, we could enter 4 compartments. We could enter in the anterior granulohumeral joint. We could enter the subacromion space. We could also enter subcoracoid space, and we could enter in bicipital groove. But when your patient have the AC joint, it will become a chronic shoulder pain. And not I use the other entry point at the AC joint. So I have a line. The name of the line is my line, Alif line. That above the line is the we could not enter the granulohumeral joint, but below the line, it must be entered the granulohumeral joint. And I use that line. The line was from coracoid, go to the greater tubercle, and below the line, I measure with the I measure with the needle, and I make sure the needle is below the line. When my needle is below the line, so it must be it enters the anterior granulohumeral joint. So it depends on your problem. When it's involved the AC joint and not just I use the entry point from the AC joint, but when it's not involved the AC joint, I use the entry point from the coracohumeral ligament. Thank you.
Thank you, sir. One more question is there over here by Dr. Vivek Chavdi. Any specific pattern or point of injection for joints?
Okay. For PROL0THERAPY for the joint, there's new experimental studies that mention about dextrose 1% it also make proliferative treatment. So it depends on you. When you want to do only PROL0THERAPY, only usually for the mild pain or less or maybe moderate pain, you could use dextrose 5%. It's also safe when you use it in the nerve. When you use nerve, you do hydroneurolalysis, it will safe for you. But in some cases, you want to shut down the TRPV1, you use dextrose 12.5%. Okay. But in the common cases, especially for nerve, you could use dextrose 5%. For beginner, you must use dextrose 5%. Why? It's safe for you. When you inject something there, is nothing happen. When you get a wrong side. Okay?
Yeah. One more question by Dr. Dharmavati. In spine, what kind of cases did you use the PROL0THERAPY? Did you put dextrose in the transforaminal epidural? And how is the patient's improvement?
Okay. Dextrose, when I use transforaminal epidural, I use dextrose 5% or less than 5% only. Why? It's safe for you. There's no nerve injury or they only nerve injury level 1. So the most risk and the complication for use dextrose 5% is only make your nerve become neurolysis only. It's not become axonal-mesis. So when you use for the transforaminal injection at the spine, you could use from 1% until 5%. Don't go far away from 5%. It's your cutoff. And what kind of PROL0THERAPY that I use for the spine? First, I use especially for chronic pain. Second, I use usually for the cases with the that I mentioned you before, compression, but without motoric and sensory changes. And the patient doesn't want to go to operating theater. Third, I use usually for the acute pain, usually around the muscle. Usually I use from the ESP. I use now for ESP, put it the dextrose 5% there, and they have the similar effect with the bupivacaine. It's nice. That's the cases that I use it for the spine cases. Okay.
Okay. I think the last question is for diabetic patients, how do you set up the dose of dextrose?
That's a good question. Why? Sometimes we think when we use dextrose, we will make elevated the blood sugar. No. When we use only dextrose in compartment only, and you must make sure that not enter in the blood flow is safe for you. Yeah. There's experimental studies that use dextrose 25%, and they check about the blood sugar of your patient and safe. So when you injected your dextrose, whatever the dose, whatever the concentration, make aspiration first and make it sure that not enter in the blood flow. When you use PROL0THERAPY, especially dextrose, and it's entered the blood flow, voila, it will make your patient go down. It will make the blood, the glucose sugar will increase up and up. That's your problem. So be careful, be nice, be humble. Don't do overconfidence. Play safe. Do the basic thing. Thank you.
Thank you very much. Those were the pearls, clinical pearls from the master himself. So I think those were the doubts. I don't think there are any more questions in the chat box. So again, thank you very much, Dr. Alif, for accepting our invitation. And before I let you go, I want to make one announcement. The announcement is that for our Algos Academy of Medicine, we are very proud to include Dr. Alif Rahman as our first international faculty.
Thank you
Sir,
very much.
thank you very much, sir. Sir is our first international faculty of our Algos Academy of Medicine, and with sir's expertise and knowledge, we look forward to move ahead in the field of pain education.
Thank you very much.
Thank you very much, sir. So moving ahead, we'll be moving on to the next topic. I will be presenting on PRP.
Could I
So
leave this
yes,
Zoom meeting, Dr. Javed?
yes, sir. Yes,
Because
yes.
I still have a patient now. I have the team procedure that I must do that. Thank you
Sure.
very much for your kindness. Thank you very much for your humbleness. Thank you very much for your hospitality. Thank you very much, all my friends from India. We look forward for you go to Jakarta. Thank you very much.
Thank you.
Bye-bye.
Thank you, sir. Thank you. That was Dr. Alif.
Thank you.
And
Bye.
now moving ahead. So before we start the next topic, I just want to share a bit about our academy and the courses what we do. So this is the Algos Academy of Medicine. So we have our motto, which is knowledge, innovate, and thrive. So we have our list of courses. We do quite a number of courses. One of the one is the FIPP preparatory course. Now, FIPP is the Fellow of International Pain Practice exam. So this is an exam and certification awarded by World Institute of Pain, USA, and one of the most recognized certifications all over the world. So it is a comprehensive course to help crack the exam, because we know the FIP exam has its own different components like the theory, practical, and everything, and the procedures on the cadaver. So this course is a totally online course, which helps candidates prepare for the FIP exam. And the new batch will be starting from next month. So this is our success stories of the last year candidates. So we had candidates who gave the exam in Budapest, in Turkey, Taiwan, etc. And the candidates have successfully cleared the exam. We also have a hands-on preparatory course wherein candidates come to my place over here in Bangalore, and we have like a 2-day course wherein comprehensively we train them on the procedures and give them like a mock examination of the FIPP, how it is going to be, and prepare them for the exam. It is done on mannequins made from real bones, okay? And usually 1 or 2 candidates per batch is only what I take, so that they get dedicated attention and help to crack the examination. Next is we have the EDPM courses as well. EDPM is European Diploma in Pain Medicine. Okay, as you know, EDPM, there are 2 EDPMs. One is by European Pain Federation and other is by ESRA. So this is more directed towards EFIC EDPM, but still we had many candidates who cleared the ESRA EDPM also by attending our courses. So different courses we have for part 1 as well as part 2. Part 1 is an online exam and part 2 is on-site exam where you have to go and write. And this is our success stories of the candidates. You can see on top, we have candidates who cracked the EDPM by European Pain Federation. And below, we have candidates who have cracked the ESRA EDPM as well by attending these courses. So we also have courses for candidates who are looking to enter into pain medicine. This is the fundamentals in pain medicine, the basic course in pain medicine, wherein it also has an online and an offline portion. Okay. So we do this as well for candidates who want to come over here and learn also, and also learn online. We also have a very exciting anesthesia exam preparatory course, wherein we train the candidate, the postgraduates who are doing their MD or DNB final exam. Okay, it's also a totally online course, and we have our star faculty, Dr. Sunita. So Madam is an examiner for the DNB and the MD final exam. So dedicated faculty student interaction is there, and we help them prepare and clear the exams as well. So moving ahead, we also had a workshop in last month, and these are the few scenes of the workshop. This was a ultrasound guided workshop where we focused on upper limb model and knee interventions as well. Okay. And moving ahead, we have a new course added. So I would like to invite Dr. Bablesh Mahavar. I think ma'am is there with us. Madam, if you're there with us, kindly unmute yourself and you can talk about a new course which we are planning to offer the candidates.
Thank you so much, Dr. Javed. Good afternoon, everyone. It gives me immense pleasure to announce that there is a collaboration and integration between Algos Academy and the Prayatn Care Pain Medicine clinic. So here we announce the integrative palliative care course, which is a course for the doctors starting from their MBBS and mainly for the pain physicians and whosoever are pursuing the interventional pain medicine. Because as we know that the management of chronic pain is totally different from the management of cancer pain, in which there is much more integration of palliative care we come across, and it does not deal only with the cancer pain but also with so many other diseases like stroke patients, like dementia patients. So that is all about this course, and this course will be starting almost in the first week of July, roughly around a 2.5 to 3 months time, and it is roughly around 2 days in a week, and we'll be covering around in a comprehensive way all the major topics, and with the renowned faculty of India, including the Padma Shri awardee Dr. Raj Gopalan, with the introduction of palliative care. And that's all I would like to thank you all. And I would like more and more people should join us to have a comprehensive knowledge of pain along with palliative care, because management of cancer patients and palliative care is a totally different ball game altogether, in which you require lot of communication skills, lot of empathy, and lot of conservative management as well, along with the interventions. Thank you so much.
Thank you very much, ma'am, for describing about the course. So as ma'am rightly said, managing pain and managing palliative care is a totally different ball game. And the focus, the center of attraction of our course is the same. It's a course for doctors, and it is going to help you integrate palliative care into your day-to-day practice. Thank you very much, ma'am, for being a part of today and explaining about the course.
Thank you. Thank you so much. Yeah.
Okay. So moving ahead, let us start with the second topic for today. And the second topic for today is going to be PRP. So PRP, as we all know, is one of the most go-to treatments. A lot of people nowadays are practicing PRP. So let's have a look of, how PRP is, and a bit of basics and a bit of practical aspects. I'll be focusing more on the practical aspects and the clinical aspects in this lecture. I'll start sharing my screen now. Do let me know once the screen is visible. One of you can unmute yourself and you can let me know the screen is visible. My screen visible?
Yes, sir.
Thank you very much for the confirmation. So let's start. Platelet-rich plasma. Myself, I'm Dr. Khaja Javed Khan. I am a consultant and director of Algos Multi-Specialty Pain Clinic from Bangalore. So we'll be doing today's class under the following headings. We start with a brief introduction and then go into the preparation part, how it is prepared, its applications in pain medicine, the advantages, the future directions, and the conclusion. So starting with the introduction, what exactly is PRP? PRP is a short form. The full form is platelet-rich plasma, and this is defined as a portion of plasma fraction of autologous blood having a platelet concentration above baseline. So in simple terms, it's a plasma concentration wherein the platelet count is going to be higher. So look at the normal plasma. What does it contain? It contains red blood cells, contains white blood cells, and it contains plasma, contains platelets, etc. Right? Now, the PRP is quite a popular therapy for a variety of indications, including musculoskeletal and degenerative conditions. Best part is it enables natural healing from the body's own blood, from the patient's own blood, using his or her own natural growth factors. And they contain, platelets contain a lot of growth factors and cytokines that affect inflammation, post-operative blood loss, soft tissue, muscle tear, healing, etc. Now let's have a look at how it is prepared. So there are two methods. Of course, a lot of methods are there. But again, the two common methods are the PRP method and the Buffy coat method. So what is the difference between the two? PRP method, here initial centrifugation is done to separate the RBCs, okay, and then followed by a second centrifugation to concentrate the platelets, which are suspended in the smallest final plasma volume. What is the Buffy coat method? In Buffy coat, the whole blood is centrifuged at a high speed with subsequent collection of Buffy coat, and this Buffy coat contains a high concentration of leukocytes. So let's have a look at the PRP method. Now, of course, the blood is obtained by doing a venipuncture into the tubes containing anticoagulant, that is ACD. The blood should not be cooled down or chilled at any time. Okay. And first, a soft spin or a spin with lesser RPM is done, centrifugation. And then after this is done, transfer the supernatant plasma containing platelets into another sterile tube without anticoagulant. Then centrifuge this tube at a higher speed or harder spin to obtain a platelet concentrate. The lower 1/3 is PRP, upper 2/3 is platelet poor plasma, and at the bottom of the tube, platelet pellets are formed. Remove the platelet poor plasma and suspend the platelet pellets in a minimum quantity of plasma, 2 to 4 ml, by gently shaking the tube. So this is how you can see venipuncture was done. Collection of around over here in this case 30 to 35 ml of blood is done. First spin is done, and the upper layer of the buffy coat is transferred into separate tubes, right? And then a second spin is done, and collection of platelet pellets with few RBCs at the bottom is seen. Can you see the platelet pellets there? Okay. And then homogenize the platelet pellet by thoroughly mixing into lower 1/3 of plasma, discarding the upper 2/3. And we have ready to use 5 ml of homogenized PRP. This is the PRP method. Let's move ahead to the buffy coat method. Now, buffy coat method, the blood is stored at 20 to 24 degrees Celsius before centrifugation. Centrifugation is done at a high speed. Okay. And once the centrifugation is done, 3 layers are formed. Bottom layer is RBC because it sediments down due to heaviness, and middle layer is platelets and WBC, and topmost layer is platelet poor plasma. Now the supernatant plasma is removed from the top of the container, and the buffy coat is transferred into another sterile tube, and centrifugation at low speed to separate the WBC, or you can use a leukocyte filtration filter. So here we saw blood was withdrawn, the whole blood is taken, and platelet separation occurring through centrifugation. Here what we are seeing that after centrifugation, it is separating, right, into red blood cell, platelet poor plasma, platelet rich plasma. And then that platelet rich plasma is taken and injected into the area where it should be injected. So in my practice, I use a buffy coat method. Now, as we saw, 3 simple steps were there. First is collect the blood, then centrifugation. Again, I use commercial kits, so the centrifugation, RPM, and duration all varies. But important recommendation is to have platelets 5 times the normal. Extract the PRP, and activation can be done or cannot be done. We'll talk about activation later by addition of thrombin and calcium chloride, or as per the kit used, and inject in the area under all aseptic precautions. Let's have a look at the different indications of PRP. Indications include joint pains, tendinopathies, ligament or muscle strains, chronic sports injuries, nerve injuries, bone repair, sometimes in surgeries like plastic or oral surgery. Contraindications can be divided into 2, absolute and relative. Absolute are thrombocytopenia, platelet dysfunction syndromes, septicemia, infection, patient not giving consent. The relative include consistent use of NSAIDs within 48 hours of the procedure. Whenever a steroid injection has been done at a particular site within 1 month, and systemic use of corticosteroids if they are done, then within 2 weeks. Recent fever or illness, cancer, especially hematopoietic or of bone, hemoglobin less than 10 grams %, and platelet count less than 1 lakh. So let's have a look at the different growth factors in PRP. So growth factors are contained in platelets, okay, and they are going to help stimulate cellular growth, proliferation, healing, and cellular differentiation. A lot of growth factors are there. Common ones are platelet-derived growth factor, transforming growth beta, fibroblast growth factor, insulin growth factor, VEGF, vascular endothelial growth factor, epidermal growth factor, etc. Now, how do these growth factors serve? They help by stabilizing the damaged tissue during initial stages of tissue repair. They direct the local mesenchymal and epithelial cells to migrate, divide, and increase collagen and matrix synthesis, ultimately leading to fibrous connective tissue and scar formation. What is the most important thing for us to realize is the platelet concentration in a PRP should be at least 5 times. There are a few factors which influence the platelet yield. Now, what are these factors? One is drawing of blood. To avoid unintentional activation of platelets, most protocols use large bore needles, more than 22 gauge, to draw the blood. Centrifugation process is also a very important factor influencing the platelet yield. The number of RPMs and duration are very important. Temperature, ideally 21 to 24 degrees Celsius is what is preferred. And among anticoagulants, avoid EDTA. EDTA should be avoided because it damages the platelet membrane. Citrate and dextrose or sodium citrate are what are recommended. Now, coming to activation of PRP. So, activation of PRP, again, exogenously it can be done using either thrombin, calcium chloride, or mechanical trauma. But remember, collagen is natural activator of PRP. Whenever you are using PRP for indication for musculoskeletal conditions, most of the time collagen will already be there near the tissue. That itself will naturally activate PRP. There is no need to separately activate the PRP in your musculoskeletal use. I use primarily for musculoskeletal indications, and I don't use any activators separately. So let's come have a look at the different PRP preparations. There's something called pure PRP or leukocyte poor PRP. These are preparations without leukocytes. Okay. There's something called pure platelet-rich fibrin. This don't have, again, leukocytes. They have a high-density fibrin network. They only exist in a strongly activated gel form and cannot be injected or used like traditional fibrin glues. Leukocytes and PR. This is the one is commonly used. So they have, this is a mix. We have leukocytes and the low-density fibrin network after activation. Most commercial systems have this variety, and most kits need minimum handling of blood samples and maximum standardization of preparations. Coming to leukocyte and platelet-rich fibrin, again, this is second generation PRP products with high density fibrin network and with leukocytes. So let's have a look at the applications in the field of pain medicine. So hip joint, this is a musculoskeletal indication if you see, then be it different large joints like hip joint, PRP or PROL0THERAPY can be utilized. Okay. And here you can see, I prefer using a hybrid approach using both ultrasound and CM to confirm the injected. Knee PRP is also quite common. Okay. And we use it for different indications, be it degenerative conditions or ligament injuries or tears. Okay, it's used. Ankle joint, you can see over here. And wrist, also it is used. Also in conditions of the spine also. And the shoulder PRP is used. Cervical spine, I do cervical PRP and PROL0THERAPY as well. And even for the lumbar spine as well. So this is a video about the PRP. Let's have a look about how PRP is.
Well, ultrasound practice has revolutionized the way how we do intervention. Show an arthritis of which is come for the second session
This
now.
was a patient
So with the ultrasound guidance,
knee osteoarthritis, okay, stage grade 2. So here I'm doing a second session of the PRP for the patient.
Knee joint injections, we do. So if you see this model of the knee, we'll be visualizing the
here we are seeing
ultrasound guidance.
We are in
I will
OT,
be visualizing
and here we are going to do the procedure on the patient. Okay, we are using the ultrasound guidance. This is the ultrasound. We have placed the ultrasound, and we're trying to find the suprapatellar recess into which the injections are usually done. Okay, of course, in this patient, it is a bit thin, the area, but using the ultrasound, again, it's becomes a lot useful to help identify that. Here, if you see, okay, I think just go back a bit. Here, can you see that this one over here? This is the suprapatellar recess. Hope you are able to see it. This is the SPR or the suprapatellar recess. Okay. Coming to the other layers, this is skin and subcutaneous tissue. Okay. We have the quadriceps tendon on top. And here, this is going to be the bone, right? There's the femur here. Okay, so injectate is going to be injected over here, the PRP. Fine. Let's clear this up and continue the video. Now here, this is, we can see the joint line. Okay. Now here we are seeing, okay, we place the probe, and now we'll be starting. You can see the recess also over there that we annotated previously. Okay. Now you can see ergonomics is very important. Okay. And better to be in one single line, U, and then the probe and the ultrasound machine. Okay. So here you can see we're giving first a bit of local anesthetic. Under sterile aseptic precautions, we're doing this procedure. Okay. Give some local, good amount of local, so that the pain is less to the patient as much as possible. You can see the needle there. Okay, going in. So I usually prefer angiocats, putting it in and then injecting the PRP. So I think you can see here the angiocat going in. There is IV cannula, etc. And here you can see the PRP is being injected. Can you see the spread now? Okay, so that was about the PRP injection. Okay, and this was for second session for patient with knee osteoarthritis. Now, the next very important thing which all of us have in our mind is you have done the PRP injection, but how to focus on post PRP, because doing the procedure is one thing, but only thing is the patient is going to have improvement after a certain period of time when we are doing PRP. So remember, for post PRP rehabilitation, you have to understand the mechanism over here. That is the rehabilitation. Okay, it occurs in 3 phases, right? So one is the inflammatory phase, other is the proliferative phase, and next the maturation phase. So you can see in inflammatory phase, there is going to be inflammation. Okay. Along with it, a little bit of granulation tissues starting to occur. Okay. And then in the next proliferative phase, you still have the granulation occurring and then wound contraction happening. And in the maturation phase, when you go, there is collagen accumulation and remodeling happening. So this is a simple rehabilitation protocol, which you can keep in mind whenever you're prescribing PRP for patients. So we have 3 different phases. Okay, phase 1, phase 2, and phase 3. So phase 1 is called tissue protection. Okay, number of days 0 to 3. So the restrictions is consider non-weight bearing or protected weight bearing for lower extremity procedures, especially if in pain. The patient should not do any weight training. You have to avoid NSAIDs and use limited ice.
Jangan jauh-jauh. Yeah.
In the rehabilitation part, what you can do is take relative rest, activities as tolerated, avoid excessive stress. Okay. Now, coming to phase 2, that is early tissue healing, facilitation of collagen deposition. Days 4 to 15, you can progress to weight bearing exercises, but functional weight bearing without protective device. Again, avoid NSAIDs. You can ask the patient to start light activities to promote rehabilitation, that is movements, aerobic exercise, etc. Gentle stretching also can be done. In the weeks 2 to 6, avoid eccentric exercises, avoid NSAIDs, avoid ice, and you can start progressive weight bearing activities. Okay, and dynamic stretching also. Phase 3 is collagen strengthening. So week 6 to 12, eccentric exercises. Okay, progressive weight bearing activities can also be started. And 3 months and above, reassess the improvement. If not more than 70%, then consider repeat injection and return to phase 1. And if you're getting good improvement, then progress back to functional sport specific activities with increasing load on the tendons and muscles. Moving ahead to the future directions. So if you look at stem cells and stem cell therapies, you can see what by stem cells and what stem cells. Second. If you look at the stem cell, what exactly the stem cell? A mesenchymal stem cell is a primitive cell, right? With the ability to reduce inflammation, fight apoptosis, differentiate into multiple tissues, and self-replicate. And they also have regenerative potential to develop into muscle, tendon, bone, or cartilage that replenish dead or dying cells in injured site. And sources of adult stem cells for therapy are either the bone marrow, okay, or the adipose tissue origin. Now coming to bone marrow concentrate. So bone marrow concentrate, as we just saw, what does it actually contain? It contains hematopoietic stem cells, mesenchymal stem cells, endothelial progenitor cells, and it 4 to 5 times increase progenitor cell slaughter from baseline level. How does it help? Concentrated cell loads accelerate the healing cascade, and the EPC, endothelial progenitor cells, support the vascular cell structure, and the HSC, hematopoietic stem cells, produce platelets, which modulate the regenerative process, mediate cell-to-cell adhesions, and promote wound healing. So to conclude, PRP is a vehicle to deliver large amount of important growth factors which are biologically active to the injury site. Its use has extensively risen over the last decade due to advanced technology and availability of newer commercial PRP kits. It's a very simple and easy to use, easily available because it uses patient's own blood. It's autologous, cost-effective, and considered very safe therapy. Thank you very much for patient hearing. And you can ask me if you have any doubts. If you have any doubts about PRP, you're welcome to ask. And either you can put it in the chat box or you can directly ask me. Okay, so we have a question from Dr. Steffi Wang. Thank you for the presentation. May I ask how to decide when to use PRP or PRF? PRF, are you meaning to say pulsed RF? Are you asking me? So if it is the same, if you mean PRP or PRF, if it is PRP or pulsed RF, then I would say that, okay, platelet-rich fibrin. Okay. So again, platelet-rich fibrin, or what is usually done is it all depends on the patient and the condition usually. And also one very important thing is the patient affordability as well. So over here, we get the PRPs quite commonly. And what we do over here is, we use more of PRPs than platelet-rich fibrin, because one thing is the affordability comes into the question, and also from the commercially available kits. So what is very important is, especially the platelet-rich fibrin, you can choose it more if you're dealing with ligament injuries or muscle-related tears. It gives a good result. Of course, PRP also gives good result, but PRF is a bit more better because it's more like a glue. It goes and attaches, sticks to that point where there's a tear. Whereas PRP can be used for degenerative conditions and also the tear conditions as well. Hope it answers your question. Next question, what exactly is first stage and second stage PRP? How many stage do we have to do? Okay, see, so basically when you do the preparation of the PRP, as I said, I use the Buffy code method. The first stage, we just, do a centrifugation and then separate out. So the mixture plasma still contains a mixture of platelet poor plasma and platelet-rich plasma. So that was the first spin or the first stage. Next, we go on to the second spin or the second stage, wherein we do a centrifugation and concentrate it even more, so that we get the Buffy coat which contains the PRP. So this is the second spin for the PRPs. And usually about the sessions for PRP, I think how many, you mean to say how many sessions we have to do. So it depends on the indication. So as I said, if it is early stages of osteoarthritis, then even one session is more than sufficient for patient to get good relief. Whereas if it's a later stage, like stage 3, you might require at least a minimum two to three sessions. If you are dealing with something like a tear, shoulder supraspinatus tear or a ligament tear, then minimum 3 sessions are required. from the literature and evidence as well, and from my personal practice experience also. I usually give an interval or a gap of 3 to 4 weeks between each of the stages or the sessions. Okay, and then do the sessions of the PRP. But one thing what you have to remember is ultrasound guidance is very important whenever you're doing PRP injections, because you have to inject at the exact site to get the best possible response. And once PRP is done, as you saw the slide I had shared on post-PRP rehabilitation, it should be followed to the T. Otherwise, the results will not be very optimum. Okay, and physiotherapy rehab carries its equal importance. So after you're doing PRP, make sure you are doing these as well. Somebody is asking, if we don't use commercial kits, how can we determine if our platelet concentrations are enough? So if you're not using commercial kits, again, in this part of the world, a lot of people are doing PRP, but not using a lot of commercial kits. So they just use a test tube, centrifuge it, and then they use. But again, you don't know what is the concentration. So for that, what you have to do is you have to send your PRP samples for lab testing. And then only you will get to know whether it is the optimum platelet, that is 5 times more or not. Do you have any experience with light activated PRP? Yes, basically, as I said, the activation of the PRP is going to, what it does is it is going to break open the PRP and release the growth factors as soon as you are injecting it. Okay. As we just saw, either could be calcium chloride, for example, or thrombin. So these are going to help activate the PRP. As I said, I usually use it mainly for musculoskeletal indications. So collagen is almost there most of the places where we're injecting. So it directly activates the PRP. The only thing over here is to get maximum result from the PRP, what you are injecting. Any other doubts? So you can ask me. Okay. As I had shared regarding courses, so if anybody of you is interested to enroll into any of the course, I am just putting the number. You can directly contact me. The number in the chat box, as well as I will be sharing it as well. Okay. So this is our number, and this is our academy. Number is +91 79758 96550. Okay. If no doubts, then I think we are coming towards the conclusion of today's webinar. So I'll invite Pavitra to take over from here.
Thank you, Doctor, for this wonderful webinar. Hello?
Yes, you're audible. You're audible.
Yeah. So, like, you can get access to this recording and also the other videos by subscribing to our YouTube channel. And our YouTube channel name is Algos Academy of Medicine. And we also have our Instagram page. So you can follow our Instagram page, that is Algos Academy. So you will be getting all the updates on our Instagram page as well. And thank you all for joining us. And also stay tuned for the update on our upcoming webinar. Thank you so much. Thank you, everyone.
Thank you, Pavitra.